But with that, I will just let you kind of say a few opening remarks, the two of you, and then we'll jump right into the questions.
Thank you so much. I think this is such an apt topic to end the month of March on, given it's Endometriosis Awareness Month. And like, what could be better than having a gynecologist and a fertility doctor, because that's really both ends of the spectrum in terms of issues that endometriosis patients face: pelvic pain, medical and surgical treatment, which Dr. Liu is a complete expert on, and fertility care. How do I get pregnant? What kind of treatment is going to be best to get me pregnant? How do I deal with pain that can arise in between pregnancies? So really excited to be here and answer questions. And I'll let as well.
And same, I'm just going to echo Dr. Sharma's comments. And I really have to say thank you to Treehouse for giving us this platform to talk about a disease that really affects our mothers, our sisters, our loved ones, our friends, our daughters. And it's something that is high time that people really took a serious look at this, because it affects so many women. So thank you.
Well, thank you. And I thank you to everyone who is interested in learning more today. So with that, let's get going, as many people are rearing to go and we're getting questions coming in. The first question is there a link between endometriosis and infertility?
I'll take that one. Dr. Liu can certainly add to this. So yes, absolutely. First off, like a quick blurb on what is endometriosis. So yes. Endometriosis, where tissue that's similar to the uterine lining, the endometrium, is growing outside the uterus. And so there's many different places that it can grow. Typically can grow all over the pelvis, on the outside of the uterus, in the line of the pelvic cavity, around and surrounding the fallopian tubes, in the ovary as cysts, or on the surface of the ovary. It can even be on the bowel. And there's also odd places it can show in the umbilicus, which is the belly button, on the diaphragm. And there's lung endometriosis, brain endometriosis, but typically what we're focused on as infertility specialists is in the pelvis. And so given the wide variety of areas it can affect, endometriosis can affect your ability to ovulate. It can affect the ability and the effectiveness of follicle or egg growth. It can affect egg quality. It can affect ovulation itself. The inflammation created by endometriosis from inflammatory mediators that are secreted when endometriosis is active can affect implantation. So really all aspects of getting pregnant. It can cause blocked tubes. It can cause small or large ovarian cysts that can affect the ovary's ability to stimulate with medication, and also affect the quality of eggs. So I see a ton of patients who come to me with endometriosis, and that's where we often have to get the evaluation by an expert surgeon like Dr. Liu, because we always have this question of, should we go in and diagnose it with surgery and remove it before fertility treatment starts, or should we leave it alone and do treatment and get the patient pregnant? And so Dr. Liu can comment on infertility patients she sees and surgical aspects of endometriosis.
Yeah, I think that's a great connecting, since a few of the questions came in, that is endometriosis going to impact my pregnancy? And so let's maybe start there, and then we'll go into some of the complications and how it can affect maybe even giving birth. But I'll turn it over to Dr. Liu.
Yeah, I'll let Dr. Liu.
First of all, it's true, just like Dr. Sharma said, it can affect the whole range of a reproductive lifespan. So in terms of fertility, just like Dr. Sharma was saying, it can affect the patient's ability to get pregnant. And traditionally, we used to think that it was something that, really once somebody gets pregnant, they're home free, that's it and that's good. But I saw the question coming in, where endometriosis, can it affect my pregnancy? So that's a really hot topic these days. And I think that a lot of it also depends on the current disease burden. So it's really hard generalizations overall in terms of anybody, because patients with endometriosis have such varying degrees of disease. But we are starting to realize now that endometriosis, pregnant women with endometriosis can have certainly higher rates of miscarriage. They can also have higher rates of threatened preterm labor. And there been some signs that it can even affect placental function and growth. And so it's certainly an area that is being studied more these days in terms of looking at how once somebody does get pregnant and achieves that pregnancy state, what kind of complications they can have. But sometimes it's hard to tease out whether or not there are confounding factors as well, because remember that endometriosis, it sometimes can increase as a patient ages, and as we all know, there's a delay to diagnosis. So sometimes women are older already, and older women do have a tendency to have higher risks of miscarriage and complications in their pregnancy. So sometimes it can be really hard to determine, is this pregnancy complication because of endometriosis, or is it because of other factors that aren't necessarily related to their endometriosis? So it depends on the patient, of course.
Okay, thank you. So speaking about pregnancy, and I mean, maybe we can speak to a little bit about the pregnancy experience. Once you have been successful and conceived, and you are now pregnant, in fact, will your pregnancy experience be different if you have endometriosis?
I can speak a little bit in terms of the first trimester because it's a common scenario that I see. A patient does fertility treatment or IVF and they're pregnant and they say, well, I have these cysts in my ovaries still. Is that going to affect my baby and the first trimester? So, you know, in general, I think that most patients do well in the first trimester with endometriosis. Certainly if you have a big cyst in your ovary that we decided not to take out because you're 42 and that would have compromised your reserve, we didn't want to have to remove an ovary, we wanted those eggs for IVF and you got pregnant, certainly it's something that we'd have to monitor for symptoms of pain, somewhat increased likelihood of ovarian torsion, which is twisting of the ovary if you have a large cyst, but really it's mostly pain. And just monitoring the size of the cyst and, you know, if it's changing and if we're worried that it could be more than endometriosis and it needs to come out during pregnancy. But otherwise, I find in general, most patients do fairly well who have endometriosis and they then conceive, because oftentimes pregnancy is considered a suppressive effect on endometriosis because you're not ovulating and getting your menses during that period of time. And so oftentimes women will feel less symptoms because they aren't getting their period. That's when symptoms are the worst. So generally speaking, I can say that first trimester care is pretty smooth sailing, but I do agree that all this new evidence is coming out that maybe all those inflammatory mediators can play a role in, you know, early miscarriage and whatnot. So it's a good question to consider. And I'll let Dr. Liu speak about
Maybe
second.
Dr. Liu can speak about the later second and third trimester.
Yes, and I agree with Dr. Sharma. Like, again, traditionally we used to think that pregnancy is suppressive, and, you know, we would even tell, I remember being taught in residence, oh, just tell the patient to get pregnant and then their pain should go away from endometriosis, right? And so they should have back-to-back pregnancies and things will get better. And that's because of the suppressive effects of pregnancy on their hormone levels. What we are finding that is that although many patients, and I would say a large portion of patients, do find that their endometriosis improves during pregnancy, there are the patients, and again, it often depends on the disease burden going into the pregnancy. So if you have a huge nodule of endometriosis on your bowel, and then all of a sudden you get pregnant and your uterus is growing, and that nodule definitely could cause problems. With a growing pregnancy, pain can get worse. If a patient has a lot of adhesions between the uterus and the bowel and that uterus is growing, you can just imagine how that pain can also become exacerbated. And same with large ovarian cysts. So depending, of course, on what's happening, endometriosis in their pelvis, there's no guarantee that your symptoms will improve or get better, which is our hope. But again, if it's minimal or mild endometriosis, the hope is that your pelvic pain will improve with pregnancy.
I saw a question.
I was just going to jump into the question.
2 weeks ago, and they were asking if I go ahead and get pregnant. So it's an interesting question, and I also revert to Dr. Liu's expertise on this. many of our patients will go, our infertility patients will have surgery because we're worried that they have a big cyst or bad endometriosis, or their symptoms are really bad before they conceive. And depending on the stage of endometriosis that they're diagnosed with at the time of surgery, sometimes they'll be put on extra medication afterwards because, and Dr. Lou can comment on this as well, but there's the endometriosis that you see, and there's the endometriosis that you don't see, the subclinical endometriosis. And that subclinical endometriosis that you don't see at surgery and you're not able to remove can also eventually grow and cause inflammation that can disrupt a potential embryo from sticking or growing successfully or in your IVF outcome. And so oftentimes patients will be put on suppressive therapy afterwards, like Lupron or birth control pills, and then they can conceive. But going back to the question, I mean, generally what I see is a patient had a laparoscopy and they had mild or like mild to moderate endometriosis. We're okay to get started with fertility therapy, whether that's ovulation induction medication and IUI or frozen embryo transfer or IVF, pretty much right away. But I find that the patients who have moderate to severe disease, so you're talking stage 3 to stage 4, it might be better for them to be on prolonged birth control pills or Lupron before they undergo an implantation, just to make sure their endometriosis is suppressed and you won't have any residual effect on implantation.
Just to jump back to the question with respect to how pregnancy is affected, I wanted to ask Dr. Lou, how will having endometriosis affect my ability to give birth? Maybe we can speak a little bit more about kind of once we're ready, we're entering almost labor and delivery stage, we're at the end, or almost maybe 40 weeks or maybe after 30 weeks. And how does that look for a patient?
Well, hopefully, if they've had a pretty uncomplicated pregnancy and they've made it to term and they're delivering, the hope is that their pregnancy will progress and their labor and delivery will progress normally. It shouldn't really affect things like, their pelvis or how they deliver. The issue would be maybe if they don't have a successful vaginal delivery and they have to go on to have a C-section, then sometimes the C-section, given if they've had a lot of surgeries or what their disease is like, it can be a little bit more complicated. And often I'll have patients who have endometriosis and I know about a cyst, and then but I always say, try to have a vaginal delivery. But if we can't succeed with a vaginal delivery and you end up with a C-section, let's see if we can remove the cyst at the same time. Or let's see how much endometriosis is there. Can we distinguish it from regular decidual reaction? And can we actually treat some of the endometriosis at the same time, which is what we sometimes do. But normally I would say, hopefully the actual delivery part of it should proceed normally.
Okay. Thank you. Another question came in, and I don't know who wants to take this one, but what stage of endometriosis is endo found in the pouch of Douglas?
Oh, that one's all Dr. Lou.
Okay.
It depends how much endometriosis.
Like going back to Physiology 101, it's all you.
Whether or not there is adhesions in the cul-de-sac, is the cul-de-sac obliterated? Is it involving the rectosigmoid? So that question is kind of, it could be mild or it could be really severe. Yeah.
And so what I'm also going to say to everyone is all the questions that are coming in today, what we're going to do after this, it's going to be available for you to watch. And if you'd like to kind of follow more of this content, then also please hit that little arrow above my head and follow both Dr. Prati Sharma, Dr. Grace Liu, and follow Treehouse for more of this content. All of this information will be in a blog post. We'll also have Instagram posts with all of the answers to these questions. So, but again, please keep going with all of your questions and we'll continue onwards. Let's talk a little bit more about risks of complications. Risks of complications during pregnancy and birth with endometriosis. And then we'll shift gears and talk a little bit about IVF as well. But let's ask Dr. Lou to talk more about risks of complications right now.
So some of the risks and complications of pregnancy include things like threatened preterm labor, premature rupture of membranes, preterm birth, and there have been some anecdotal studies looking at things like decreased placental function resulting in small babies, small for gestational age babies, whether or not it's inflammatory mediators that are contributing to that. And that's more for the second and third trimester. And again, the biggest concern with the first trimester is that of increased miscarriage. So those are the complications.
Okay, good, thank you. So IVF, Dr. Sharma, is near and dear to her heart. Can I complete IVF treatment with endometriosis?
Absolutely. I mean, in fact, I would probably say in general, a significant amount of patients who have pretty significant disease burden. So I would say stage 3 to 4 endometriosis patients often will do better with IVF than other fertility treatments. And so therein lies the importance of a diagnosis. It's a little tricky because, you know, in early days, we used to think you see something that looks like endometriosis on an ultrasound, send them directly to someone like Dr. Lou, or, you know, I myself could do it, go in, take out as much endometriosis as you can, clean up the body, and then get pregnant. But then what we found was that when you go in and do these complete clean out surgeries, sometimes you take out too much normal tissue as well, because really endometriosis acts like glue in the pelvis. And so it ends up sticking everything together. And in really bad cases, you can't necessarily identify where the normal ovary ends and the abnormal ovary begins. So then what you end up doing is potentially taking out, and it's inevitable, taking out abnormal tissue and scraping off some normal eggs as well. It's inevitable. What we found, studies show, especially in women who are older and maybe have more susceptible ovaries, their reserve becomes lower after surgery. And so what we do to circumvent this often is we say, look, if your pain is really bad, you absolutely need surgery. Let's do IVF first. Let's get out healthy eggs and create some embryos and freeze them. Go to Dr. Lou, surgery so you're pain-free, and then we can do your implantation. So that's one way to do it. The second way is to say, okay, well, you have what looks like some endometriosis, but you don't have many symptoms. But we know that many patients who have endometriosis, it's really just better to do IVF and circumvent the tube, circumvent all these problems with endometriosis, do IVF. Let's fast track and go to IVF and get you pregnant. And so the pregnancy rate with IVF and endo patients is much higher than with lesser means. And we know that even with IVF, endo patients may or may not do as well, especially because they have all this inflammation going down. So quick progress to IVF is often indicated. But again, you have to look at the whole picture of the patient. If the patient's 28 years old, they look like they have mild endometriosis, the sperm is good, the fallopian tubes are open, then I'm very open to say, let's try for 3 to 6 months with something like IUI, which is, you know, easier on the patient, less costly, less invasive. But if it doesn't work, then I usually talk about either going the surgery route to remove the endometriosis and then going back to lesser means, or moving straight to IVF. So a little bit of it is patient preference and whether they want to move on quickly and if they have the financial means. But I can definitely say IVF is very successful in endo patients and probably worthwhile moving forward and moving towards if you have moderate to severe disease.
Just to continue on that note, let's talk a little bit about how does it affect egg quality specifically? Is there a correlation around egg quality?
Yeah. So what we find is when we do IVF on endo patients, the data shows that the success rate is actually 50% lower than age-matched controls. So this is women in the same age group who don't have endometriosis. And that's probably for the exact reason that you're saying, that somehow the inflammation and the endometriosis and the secretion of these inflammatory mediators like cytokines affects follicular growth and egg quality. It's not going to change the genes in the eggs, but because they don't grow as well, maybe they don't have the same receptors, they don't develop the same cells around the eggs, you're not necessarily going to get as many eggs and as many healthy eggs for fertilization. And so, yes, endometriosis can affect egg quality. So in that sense, if I have a young woman who has pretty bad endometriosis, I'm more inclined to tell her to move to IVF more quickly, just because I don't want her to get to the point where she's now 36 and maybe her borderline and she won't do as well with IVF because she also has that second hit of endometriosis.
Okay.
Or I might tell a woman who's single to freeze her eggs earlier, because I'll say, and I get a lot of these referrals from Dr. Lou, actually, a patient with endometriosis who's not desiring having kids right now, but we know she has endo, maybe she'll need surgery in the future for a cyst. We're worried about the decline reserve. It's better to freeze her eggs when she's 30 or 31, just to have that as a backup in case things do get worse.
Right. Absolutely. What percentage of endo fertility patients get out of that first trimester?
I mean, like I said, in general, I would say the majority of them do fine, but I can understand that there are some people who are going to be affected by the inflammatory mediators and perhaps have a higher miscarriage rate than patients who don't have endo. I think the beauty of doing IVF in these patients is that if you screen the embryos and you know there's no other confounding factors, you know, it was a perfectly normal genetic embryo, that, you know, that piece, which is a huge for miscarriage, is out of the way. And so the ongoing rate is higher and the miscarriage rate is lower.
Can you see me? Something happened there, technical glitch. Dr. Lou, is endometriosis considered an immunocompromised disease? One of our viewers is asking.
That's a really, really good question. You know, endometriosis is so common. It's like up to 10% of all women. And we know that the pathogenesis of it is multifactorial. So there's a lot of factors going into play. So I don't want to say it's all immunological or immunosuppressed individuals. Certainly there's a genetic component. I mean, you can have people who are actually very strong individuals have endometriosis, but it could be also, you know, some women will have very, very severe endo, but never be bothered by it. They'll have a pelvis riddled full of deposits, but they won't have any problems with infertility, and they won't have any problems with pain. And so they'll have virtually no symptoms. And up to 40 to 50% of women are like that. Whereas the flip side is you'll have that woman who is mild, minimal endometriosis, but they're debilitated by the disease. So whether or not there's some sort of immunocompromised part on that, it's very hard to say. And I think it's a very good question and something that we need to kind of study a little bit more.
Thank you. Thank you very much. Hopefully that answers our viewer's question. Another viewer asks, how well can you see endometriosis by MRI instead of a biopsy?
Should I take this or do you want to take it, Prati? Good question for you. Okay, so I think that, you know, keep in mind when we do surgery, we prefer to do laparoscopic surgery. And doing laparoscopic surgery magnifies the disease by quite a bit. And so we're looking in with a camera, and that camera magnifies everything, and then it's displayed onto a TV screen. And so I like to think that we can see a lot of endometriosis, but for sure, we're going to miss some microscopic spots, 100%. No surgeon is like completely amazing and can see everything. And that's why there's a lot of studies now looking at, you know, immunofluorescence or giving a dye or an injection to a patient prior to surgery to see if there's any way we can try to highlight or make these deposits more visible at the time of surgery because of this fear of missing endometriotic deposits. But then you also have MRI, which is really, really good. And MRI, it depends, as with anything, it kind of depends on your radiologist. So there are some amazing ultrasonographers out there who can, you know, detect endometriosis so well. They know about the sliding scan and the scale, and they try to check for mobility of all the organs, and they can pick up adenomyosis so well. And then you have, and I'm sure, you know, many of the people who are on right now will have those reports that say ultrasound XYZ, normal ovaries, normal pelvic ultrasound. So basically it's been like a very quick, you know, like minimal kind of, you know, description of what's happening. And so in those cases, like maybe an MRI is helpful. So if you have, you you know, those ultrasound reports that aren't descriptive, or if you have ultrasonographers in your area who aren't as comfortable with diagnosing endometriosis on ultrasound, then the MRI can be very, very helpful. And if you ask me which is better, it seems like the question is a little bit like, is surgery better or is an MRI better? You know, I think they're both, I think the MRI is very, very helpful because it can tell you in the deeper layers. So when we do surgery, we look at the peritoneal surfaces, but we can't see below the lining of the one of the layers of the abdomen, whereas the MRI can go into all those layers for us. So it can say, oh, there's like 4 cysts on the ovary, or there's like involvement, it looks like in the cul-de-sac extending downwards to the, you know, the vagina. And, you know, it can tell us these things that we might not necessarily be able to see just on surgery. But keep in mind, like, especially with COVID now, our OR times have decreased. A lot of things have just kind of, it's been really hard to get OR time and to treat our patients surgically. So I think that the role of the MRI and the role of our fertility specialist has really increased with time, because now we have patients where, you know, we might want to operate on them and they might want to get pregnant, but we don't have that OR time. And so in that meanwhile, it makes sense for them to see their fertility doctor if pregnancy is something that they're desirous of, right? So, and then you get that MRI just to really see how much disease there is. I've probably ordered more MRIs in the last 3 years than I have traditionally, because there's been that lag and that wait time for surgery, and I really want to know what's happening. So, yeah.
Very helpful answer. Thank you so much for that thorough response. If an embryo is normal and you have endometriosis and have a miscarriage, what else should you be looking at doing? Any other types of further testing recommended other than autoimmune?
I'll take that question, but I see another question that says, what is the chance of getting pregnant naturally if you have endometriosis? And I think that's a good segue into the second question.
Yeah.
So, as much as I say that IVF is a great treatment in endo patients, I will also take the flip side argument and say, I think endometriosis, as Dr. Liu alluded to, is a very paradoxical disease. As she said, you can have patients who have no symptoms and severe disease, and patients who have mild disease and many symptoms. So it kind of goes the same way for getting pregnant, in that I've seen endo patients where they've tried everything, bad disease, they've tried IVF a couple of times and it didn't work, and then they walk in my office naturally pregnant. So you never know. It's like what I tell my patients all the time. If there's an egg there, you're ovulating, there's open tubes and sperm, it's always possible. So the short answer to the question is yes, a patient can get pregnant naturally with endometriosis or endometriomas. There's a really historical keynote study that was published in the New England Journal of Medicine many years ago. It was a multi-center trial. And what it looked at was whether removing stage 1 to 2 endometriosis improved natural pregnancy rates. And the data was quite significant. And it showed that if you go in and laparoscopically remove stage 1 to 2 endometriosis, so mild endometriosis, that the natural pregnancy rate really skyrockets. So yes, if you have mild endometriosis and it's treated, you can get pregnant. But on the flip side, mild endometriosis is not that bad. So if everything looks pretty normal, you could probably get pregnant naturally. Now, with regards to ovarian cysts and fertility, a lot of that depends on the size. I kind of have a cutoff of 4 centimeters, where above 4 centimeters, I worry a little bit about stimulating the ovaries outside of doing IVF and freezing embryos before surgery, because when you stimulate ovaries, they can grow. So that's a little bit of a concern. And the ovaries, when you stimulate them and you have multiple follicles develop in an ovary that already has a cyst, you're putting the patient at risk for more pain and torsion of the ovaries. So all of this is sort of a risk-benefit discussion. But I agree with Dr. Liu. As much as she's ordering MRIs, on my side, I'm watching a lot of small endometriomas that don't have symptoms with, and just proceeding with fertility treatment, whether that be low-dose ovulation and fertility drugs and insemination, or IVF. And I'm just monitoring these endometriomas because they can't get in for surgery, whether it be with me or Dr. Liu. And if they get pregnant, endometriomas there, same thing. follow-up. So the answer is yes, all of the above. Yes, it's possible to get pregnant with both and endometriomas, whether or not you remove it, whether or not it's stage 1, 2, 3, or 4. Again, it's a whole picture. If you have a 42-year-old with stage 4 endometriosis, I'm going to be more prone to be more aggressive. And to answer the second question, so that deals with recurrent pregnancy loss and repetitive implantation failure, or RIF. It is probably the most common problem that we're dealing with now in the fertility world, because we've become experts at creating these beautiful, perfect, normal embryos and doing IVF, but not every beautiful, perfect embryo sticks. And I think in endometriosis, because of the inflammation, implantation failure is probably more common than miscarriage. But the two categories kind of go together, and I do see this phenomenon. And when this happens, yes, we do an implantation failure workup that often involves blood work and blood, some that are warranted, sometimes some of them that are a little bit outside the box. And then there's this whole concept of endometrial receptivity and endometrial receptivity assays. So there's a test called the ERA. It's a proprietary test that looks at the receptivity of the endometrium. It looks at whether there is any inflammation or bacteria growing in the endometrium, as well as looks at the endometrial microbiome, which is the normal flora that should grow in the endometrium. Whether or not that's completely data-driven, plus or minus in endo patients and RIF patients, who knows? But I personally think it's a valuable test to offer patients. It's costly, but it can give answers with implantation failure. There's also a very specific test for endometrial receptivity in endo patients. It's called the Receptiva. I've only started doing a couple of these tests because it is pricey and the data is not fully there. But what it does is it looks at the endometrial receptivity in potential endo patients, meaning they haven't had surgery to confirm, but you really have a high suspicion of endometriosis, or surgery proven endometriosis. And it looks at the expression of a marker called BCL2. So you take a biopsy of the endometrium in a prepared endometrium cycle and FET protocol, and you take a sample of the endometrium and send it off to the lab, and they tell you how much this BCL2 protein is expressed. And depending on the levels that are expressed, you may or may not need some medical treatment, whether it's birth control pills, surgery, or medication to help suppress the endometriosis before you move on to do another transfer. So in answer to the question, yes, there's a variety of studies that you can do in patients who have implantation failure. I don't know that I would do all of this just with one failed implantation, because that's probably just chance and you should just try again. But once you get into repetitive failures, then there are tests that are available.
Thank you so much. Perfect. So as we're approaching kind of the top of the hour here, I wanted to, we got through most of the questions, and we got some questions that we won't get to because it's just about 7 o'clock here Eastern in Ontario. But I wanted to give the opportunity to Dr. Grace Liu to speak a little bit about kind of some closing remarks here. It is, I guess we're coming to the tail end of March. It is Endometriosis Awareness Month, but I think it's just important for you to share with our viewers a little bit more about what this month means to you and what you want some of those viewers to know.
You know, in some ways, I think I am preaching to the choir here, because we're all here because we care, and because we either have loved ones or people that we care about who are affected by this disease, and even ourselves. And I don't mind saying that, you know, I've had endometriosis, and my mother has had severe endometriosis, and a lot of what I do is trying to think of ways to prevent my daughter from getting endometriosis. So I think it's amazing to have platforms like this and to increase awareness. Things like EndoAct Canada and the Endometriosis Network of Canada, they're amazing resources for people. And I guess it's the only thing I want to leave is is just saying that, to remember that, you know, endometriosis is something that we can treat from a multi-pronged angle, right? Like, so traditionally it was like medication, surgery, and then just wait for menopause, right? But now we have a lot of different ways to try to help patients with endometriosis. And I think it's important, and sadly, a lot of the time, patients have to advocate for themselves. And I'm hoping that things like this will help that change, so that we don't have that 5 to 10 year delay in diagnosis, and people don't have to advocate for themselves, and they're not being histrionic when they're period is painful, and it's not normal to have a painful period. So I think it's important to remember we have things like meditation, we have exercise, we have, involving your gastroenterologist or your urologist, pelvic floor physiotherapy, tricyclic antidepressants, neuromodulators. So there's your anesthesia people who can do nerve injections. There's all these people that are ancillary that we never think about tapping, but especially I think in the last 2 to 3 years, which has been so isolating for everybody and where surgeries have been on a hold, we now realize, yes, we can do all these other things to try to help our pelvic pain and our infertility, and even diet, right? We always forget about diet and remembering that, your body is your temple and what you take in is what's going to come out. And so we have to make sure that we are trying to be healthy in all respects so that we can help with our fertility and help with our pelvic pain. And so I think that would be the one last thing I just wanted to make sure that everybody remembers, is that it's not just medication, it's not just surgery, it's medication, surgery, and everything else that you can do to try to help.
Well said. Thank you so much. Dr. Sharma, did you have any remarks that you'd like to add as well?
Yeah, I mean, I think that was great, Dr. Lou. Thank you for highlighting all the important points, but I couldn't agree more. I think just reproductive health for women and men is just coming to the forefront now. And thank you so much for platforms like this to be able to highlight these important topics, because I think in years past, women kind of like hid out in their bedrooms when they had periods and they were in pain, right? And it was not that it's shameful, but they just said, okay, I'm going to hide and get over it and then go out into the world. And now, like, I see lots of companies giving days off when you have your period just because it's a true medical condition, just like infertility has been realized as a true condition. So you can speak up about this now. I think that, speak to your family doctor. I think getting early fertility evaluations, even if it's just to say, you know what, I get a little extra pain during my period. Is something going on? Like, you can totally come in and see me or any other fertility doctor and evaluate your fertility, see any cysts. Super easy, and it gives you peace of mind. And if need be, I'll send you to Dr. Lou, and she can evaluate you for medical treatment until you're ready to conceive. You can egg freeze. And I can't agree more that a holistic approach to the whole body is important.
Yes.
Like nutrition, diet, healthy lifestyle, exercise, especially in conditions like endometriosis. I think they can really contribute to overall well-being and improving disease symptoms. So couldn't agree more that that's really important. And, early intervention, don't be afraid to get a consult and take charge of your gynecologic and reproductive health.
Yeah, and don't let anybody tell you that you're crazy or that it's all normal, all fine. And I think that, I don't want to get on my soapbox about how women are treated. And so I'm going to try not to do that, but I think it's really important that we have a voice and that our voice is heard. So gone are the days where, I think it shouldn't be at all a thing where people are being told that it's normal to have pain, or it's normal to have a little cramping or discomfort with your period, or, just keep trying, or just get pregnant, or just do this, or, we shouldn't be minimalized like that, or, so.
No, I agree 100%. And that's really why I started this company, was mainly because I had such a passion for women's health, and it's not considered a niche market. I hate when people say, oh, it's women's health, and it's not women's health, it's just health. And it's the health and wellness and at various different stages. And we go through so many stages as a woman, from the time that we're young girls to the time we're elderly women. So we go through so many phases, and we need support during those phases. And so we're so grateful to have experts like you who are passionate about this and championing so many of these amazing therapies and supports out there in the community. So thank you so much this evening. If you'd like, again, to see more of this content, if you have more questions that we didn't get to tonight, please hit that little arrow above my head. Follow us, follow Dr. Lou, follow Dr. Sharma, get in touch with them, and we will be looking forward to seeing everyone again on our next Ask an Expert in the next couple of weeks or so. So thank you again. Have a lovely evening, and we'll talk to you soon.
Thank you. Take care.
Thank you.
Stay
Bye.
healthy.